Hello and welcome to the Racial Equity Webinar Series. I'm Kinkini Banerjee, the Senior Coalitions Relations Manager at USBC, and I'm so glad to have you join us for this session. This bi-monthly series was launched as part of our efforts to create and model a culture of inclusion, diversity, and equity with funding from the W.K. Kellogg Foundation. It's focused on building capacity of the breastfeeding field to apply both an equity lens to inform and guide our strategies and activities, and also an equity mirror to examine our internal structure, culture, and policies. The USBC hosts more than 20 online communities on breastfeeding-related topic areas from the Surgeon General's call to action and beyond. And the Racial Equity online community is one of them. So we have the webinars are held every odd-numbered months, and then we share a lot of materials and things. We often have blog posts aligned with our webinar topics, and also a forum, a community forum for discussion. There's also a really great file library for sharing general readings as well as readings related to each of the month's bi-monthly topics. So this is where you can go to join the online community, www.usbreastfeeding.org/equity-community. So if you go to our if you go to our website or to the learning community, scroll down and you will see all the different places that you can join and engage with this. So we hope, if you're not already part of this learning community, we hope you'll join today. This series was started in 2015, and these are some of the previous sessions that we've had. Most of our sessions have focused on structural barriers, institutional racism, and structural barriers. So all of these sessions have been recorded and archived, so you can go to our website, to the learning community and to the website, and with the Racial Equity webinars are, and access the recordings as well as our handouts. So again, www.usbreastfeeding.org/equity will take you to the webinar page. We have a large number of attendees today, so glad to have you all. And it's we are in listen-only mode, so we can pause for questions if we need to. Our presenter could pause, or we could just go on until the end and take questions at the end. We do encourage you to send questions as you have them. So here's how you do it. On your screen, you should see a control panel to the right of the screen. If you don't see it, it might be minimized, so just click on that orange tab and it'll pop back out. Scroll down through the different tabs, and you'll see a tab just under the audio which says questions. Click on that tab and it'll expand into a text box where you can type your questions in. And if you have any audio issues or technical problems during this session, send us your info either through the chat or send an email to office@usbreastfeeding.org, and our staff will be able to help you. And that brings me to today's topic, what stress got to do with it. So like I said, so far in this series, we focused on the underlying structural barriers to racial equity and on institutional racism. This session will focus on how an individual is impacted by the daily racism. We'll learn how inequities contribute to toxic stress. We'll hear about the positive impacts of breastfeeding on mothers and baby in reducing stress and improving resiliency. And we'll learn mechanisms to mitigate breastfeeding inequities using a compassionate social justice lens. I'm delighted to introduce our presenter for this session, Dr. Shervington. Dr. Shervington has an intersectional career in psychiatry and public mental health. She's president and CEO of the Institute of Women and Ethnic Studies. And if you haven't visited this website, please go and see what a great resource it is. IWES is a community-based public health institute. Dr. Shervington is a clinical professor of psychiatry at Tulane University, and at IWES, she directs the community-based post-disaster mental health recovery division that she created in the aftermath of Hurricane Katrina. At Tulane, Dr. Shervington provides psychotherapy supervision for residents. She's a graduate of New York University School of Medicine and is certified by the American Board of Psychiatry and Neurology. Dr. Shervington also received a master's in public health and population studies and family planning from the Tulane School of Public Health. In 2012, she received the Jean Spurlock Minority Fellowship Award from the American Psychiatric Association. We are so honored to have Dr. Shervington share with us on an issue that is so vital in our work with women and families. And with that, I'm going to turn it over to Dr. Shervington. Welcome.
Thank you so much, Kitty. It is indeed an honor to be asked to share my knowledge with you and everyone in attendance today. Actually, I want to make sure that I emphasize that you who are listening are the experts on breastfeeding, so please bring that expertise into the space today as I try to blend my experience, my knowledge on trauma and resilience. And as best as an impersonal venue like a webinar can be, I hope that with your energy we can make this as interactive as possible.
Dr. Shervington, this is Kinkini. We don't see your screen yet. So would you show your screen? Thank you.
Yes. Can you see it now?
Not yet. Yes, I do.
Okay, great. So today I'm going to be talking about stress and how it impacts the individuals. Oftentimes in these conversations, we look at the structural barriers and our focus is on getting rid of them. But then my interrogation today is going to be, so to the person who has experienced the barriers and the stress, how do we think about her family, and what can we do? So what I'm going to start with actually is the knowledge that you have, and perhaps are much more expert in this than I am. But I just want to make sure that we're on the same page. So thinking about the determinants of breastfeeding, I think the most important thing to remember, for us to remember, is that breastfeeding really reflects the relationship between a mother and her child. And to a large extent, if we're in an equitable world, the mother's internal and external experiences, the context in which she experiences her life, that is the primary driver of how this interaction is going to be. And I just want to list a few of those internal intrapsychic issues that can turns up. I will also list some of the external issues, and then we might go through them a little bit more before I get to focusing on what's happening in the mother. So of course, someone's internal world is very much shaped by the personality type that one has and one's temperament. And by personality type, I mean how one has learned to view oneself, to view others, and to view the world around you. And then that is also, your internal world is impacted by the amount of stress that's turning up in your life, and to be clear that we all have stressors in our life. The issue is how we are able to pull in and dig deep in our resilience and our efficacy. Our internal world is also impacted by whether or not we have a mental disorder, and of course it is impacted by our physical health. And to some of the external issues for a mother, it's the interpersonal relationships that she's engaged in. Oftentimes, particularly important is that of her partner and the parent of her child, the other parent of her child. She's also impacted by the norms in her family, the norms in the community, and the space, the country, the society at large, the environment, the structural environment, and her socioeconomic status. So thinking about some of those external determinants, we know socioculturally that the attitudes towards the value of breastfeeding is very important. Maybe not as significant here, but in other parts of the world, prelactal supplementation practices. And also the act of breastfeeding itself, the attitudes towards that, especially in public spaces. Also important is the market context, and in particular, what is the industry around breastfeeding and their marketing of breastfeeding substitutes, I beg your pardon, what that industry, how powerful or not it is. And then we also know that of importance is the health system itself and services. What are the attitudes of the providers? How available in terms of the hospital practice are breastfeeding substitutes? What is the prevalence of C-sections? And how is potential separation of a mother from her infant managed in the hospital, in a hospital setting? And then in terms of, we know that a majority of women now are working, and so an important factor is the workplace policies that I'm sure many of you are focused, have been working on, issues about the length of maternity leave. Are there worksite breaks? Are there private on-site room for feeding and or pumping? And just in general, the attitude of the other people in the workplace around having a breastfeeding mother in their midst. Another important external determinant is, of course, the community to which a woman belongs and in which she lives. Access to lactation specialists, do they do health worker home visits? And sometimes forgotten is, what is the community attitude around breastfeeding? Is public education and promotion of the benefits of breastfeeding something that is prevalent in the community? And I don't know if this is as prevalent here in the United States, but I remember several years ago being in the Caribbean, and there were these huge billboards saying that the breast is best. So what is the attitude towards breastfeeding? And again, another important external determinant is the attitudes of family and friends, and even their practices around breastfeeding. What have they done in the past, and the kind of advice they're going to give to the mother. Extremely important is the level of support from a partner, and perhaps equally as important is, what's the temperament of the baby, happy or fussy? And I just go off script to say that this weekend I was honored to be with my 2-month-old grandbaby, and it was just a joy to observe her and her mom and the bonds that happen around breastfeeding. Okay, so So we also know, and this is what you know, and perhaps know better than I, that there are very, very, very important and significant benefits from breastfeeding. For the infant, we know that it's just the best nutritional support for healthy organ development, the brain in particular. It also is very important for the infant's immune system and helping to fight off infectious diseases. We also know that it impacts the hypothalamic pituitary axis and stress modulation for the infant. We also know that breast milk provides protection against obesity. And in terms of the psychological benefits, just the kind of nurturance and secure attachment that an infant forms in this act of breastfeeding and suckling at the breast. And that extends to helping the infant later on really be protected from some mental illnesses, in particular those that are connected to attachment and issues around separation. So some of those later life mental illnesses for which there is shown to be some protection is depression and anxiety and substance abuse. And we also know that if a mother for some reason is depressed, that it actually does help the infant. It gives some protection in that, if nothing else, there is increased maternal responsiveness and touch, that exchange between the mother and infant when she's breastfeeding. And then for mother, on whom we'll be focusing on today, the protections are from breast and ovarian cancer, hypertension, cardiovascular disease, in particular type 2 diabetes. There is new evidence now showing that there are biologic benefits in terms of depression, in that it decreases the inflammatory process. And we also know that the act of breastfeeding can help to mitigate the intergenerational cycle of violence and abuse. So I think I'm going to pause here and check in. Kinney, are there any questions that I might answer before I jump into the section on injustice and inequity?
So far, no questions, Dr. Shervington. There's just a slight background sound coming from your mic, in case it might be just rubbing against your collar or something. So if you can, it's just a small background sound coming. I don't know what it might be. If it's tapping against anything, maybe you might want to just check for that. Thank you.
Okay. Is it any better? I'm holding it now.
No, but it's very mild. We'll go on. Yeah.
Okay. So I'm going to start this section on injustice and inequity with a quote from Perez Escamilla and Sellon. And inequities are defined as any social, economic, political, legal, or biomedical factors that prevent women from implementing their choice and right to breastfeed. And these can be framed as the lens of equity.
We lost your audio. Okay. We lost audio for a second. Can you?
Yes. Are you still losing it? I'm not doing anything other than speaking in.
I can hear it now.
Okay. My apologies. I do know that as happens in New Orleans, oftentimes that we have problems with our internet connectivity. So my apologies if it's happening at this point. we're 11 years post-disaster, and things haven't been fully, the infrastructure is not back 100%. So in terms of injustices and inequities, I just wanted to list those, starting with perhaps one of the major ones, which is poverty, and as a result of that, classism. And we do know that there is a prevailing attitude that oftentimes families of lower socioeconomic status are just not perceived as being fully deserving of the right to breastfeed. And I mentioned in quotes, except when we know about the history of wet nursing, when women were not the mothers of infants, either for issues of money or in the history of the United States, because she was a slave, was forced into being a wet nurse. But oftentimes there is this prevailing attitude that poor women are not as deserving, perhaps to the extent that oftentimes they are so important to the working class that the time necessary for her is not deemed as important. We also know that there are some sociocultural, very disempowering isms. I mentioned sexism, and in particular how this plays out for a woman is that breasts are hypersexualized for the pleasures of males, and oftentimes as a result of that, its role as a source of nutrition is not as seen as significant, and there indeed might be shaming on exposure to feed infants. Then another one of those isms is the one that I know we've all been addressing and interrogating over the past, at least since 2015, is that of racism. And with that comes, again, like poverty and classism, that people of color are not viewed as equal and as deserving. So what happens when we set up in our society injustice and inequity for some? Well, I guess perhaps the most important is the barriers that get formed, wherein there is decreased access to a woman who is impacted by the disparities, the inequities. There's decreased access to the kinds of supports that's necessary in her workplace if she's working, where she lives, her lived environment. And she just is not able to access the kind of education and support that's necessary to promote this act between herself and her child. And we also know that when these barriers exist, that to some extent they can create disempowerment at the individual level. The individual herself feels disempowered. The group she belongs to feel disempowered. And that when one is in that state of disempowerment, it really takes a lot of work to be able to find the energy to get involved in the kind of advocacy and policy work that is necessary to overcome some of these barriers that exist in our society around breastfeeding. What I, however, would like to focus in on some is what happens to the individual herself, the woman herself, when she is in an environment of inequity. She lives the experience that she's having with her life is inequities and disparities. And we do know now, the evidence is there, that these conditions can create toxic stress-related health conditions, wherein there is a decreased psychological efficacy and resilience. And ultimately, these stressors can lead to mental health conditions such as post-traumatic stress disorder, to depression, to substance abuse, to violence, and an increase in the amount of adverse childhood experiences, as has been shown in the work of Felitti, and also to adverse community experiences. And then, if there are compounding stressors, wherein within that environment of inequity, inequalities, there is not enough social supports for the woman, if indeed she's having relationship problems with her partner, if her infant is ill, if there's prematurity, if she's experiencing pain, if she experiences insomnia, which is very, very key in issues of depression, and if there is just any history of mental illness, we know that these stressors compound that of structural inequities and inequalities. So what happens to her is that we oftentimes see a negative impact on her self-esteem, her sense of worth, her sense of value. And that becomes very important because we know one of the important tasks of mother is to demonstrate to her child, to mirror their self-worth and their self-esteem, to be able to hold and bind her infant's anxiety. We also know that living in a lot of toxicity, a lot of can just decrease one's efficacy, one's confidence in believing that one can address the stressors around them and one can be resilient, that one can bounce back. And as mentioned earlier, that these conditions can lead to trauma-related illnesses like depression and anxiety. And ultimately, this just decreases the mother's motivation for breastfeeding. So how do we work towards equity? What can we do? And I think the issue, equity is simply defined as fairness, as having equal access to. And so how do we begin to move towards that? I think it really begins in the heart space, in that we see everyone and we value everyone equally. And if we do that, then in spite of what has happened historically, if we at this moment in time value everyone equally, then that motivates us towards mitigating and eradicating the existing biases and inequities. And we know that these very much impact the social determinants of health and affect health outcomes in the long run. So moving towards equity, we have to address, interrogate issues around housing. Is there fair housing practices? Transportation issues. How easy is it to access transportation, in particular for health-related appointments? What is the quality of the environment in which a woman and her family lives? What are the opportunities for education? We know that education is a significant contributor and factor in achieving health. What does employment look like? Are there fair labor practices? And for some women, especially poor women of color, the environment and the interactions they have with law enforcement and the criminal justice system is very much impactful on achieving positive health outcomes. With that in mind, focusing on breastfeeding, how do we create a culture of health in which breastfeeding is normalized and seen as an healthy or the best and healthiest option for mothers who are able to? And I assume that this is the work that so many of you are involved in, building the leadership to get to the advocacy that will create the political will to legislate the laws and policies that support all, and I underscore all, mothers' rights to breastfeed. And in particular, those who are in service industries and in the informal labor sector. We know that sometimes these policies don't impact them as positively as they do for other women. And it also an important part of the leadership and advocacy to the extent wherein breastfeeding substitutes compete against breastfeeding, then we work to build the leadership and ultimate advocacy to attempt to minimize the availability, especially in the very early hours and days after delivery. And we also know that we have to focus in on poor women of color because they tend to be targeted. I also think that to create a culture of health for breastfeeding, we have to do some very difficult and oftentimes hard to begin to address those customs, those religious beliefs and social norms that diminish the value of a woman, and in particular the value of her breastfeeding. And that means that we, as I mentioned earlier, will have to look at how women's bodies, women's anatomy are hypersexualized, oftentimes for other people's pleasure, for men's pleasure in particular, and also those customs that shame women who breastfeed in public. And I just happen to have working a co-worker who has a 5-month-old infant, and of course she got as much leave, maternity leave, as was possible, 4 months plus, and has all those things we talked about in the workplace. But yesterday I asked her, how do you breastfeed in public? Do you cover? And she said, no, I don't. I don't cover my breasts in public. I feel very confident to breastfeed my child without covering because I do not feel ashamed. And she said the most important thing for her really is the support she gets from her husband. When he's around, if anyone dares to look at them funny, he looks back at them funny and they avert their eyes. I think very, very important, as I have tried earlier to talk about, and I can go in more details if anyone wants me to go back and speak a little bit more about some of the psychological issues that stress creates in poor women. I'm happy to do so. But we also know that in many communities, mental health treatment is very stigmatized. Sometimes for good reasons. We know that there has been a not so good relationship with certain groups of women and the mental health, just the health system in general. So in addition to that, there are certain beliefs that see mental health treatment as a sign of weakness in our communities, but oftentimes make the case that living in poverty, living in inner cities, being a person of color is so very stressful. There are so many stress-related psychological conditions that can ultimately lead to significant mental health problems, that these are the communities that most need culturally responsive mental health treatment services. And so if we're going to be really caring and concerned about poor women of color, we really have to look at some of these attitudes around health-seeking behaviors around mental health. We also, in creating a culture of health, have to address the impact of the isms on someone's psyche, as I've tried to lay out, that ultimately this can become so stressful that they can lead to psychological disorders. And as the evidence is showing us now, that there is a significant correlation of being exposed to adverse childhood experiences before the age of 18 and being able to have optimal health as an adult. We do know that as the number of ACEs increases in an individual, it can shorten their lifespan and it can make them more vulnerable to certain addictions, to obesity, and to cardiovascular diseases. So creating a culture of health means that we have to look at how, at a community level, we minimize a person's exposure to physical, sexual, and emotional abuse. How we can minimize the kinds of household dysfunction that we know are connected to trauma in a child. So parental incarceration, parental substance abuse or mental health problems, and parental divorce create a lot of dysfunction and chaos in a young person's lives and contributes to their adverse experiences. And we also have to try to minimize emotional or physical neglect. Creating a culture of health also requires that we have to work towards building the self-esteem and body pride and self-efficacy in young people, especially in girls. We need our girls to feel good about their bodies, to feel good about themselves, and to feel that they have the capacity to address the challenges that they face, just as much also as we need a similar process in our males. Creating a culture of health also requires that we think about the people like yourselves who work in this area, that in your workplace burnout is addressed, and it's a workplace that moves towards having compassionate environment, as reflected in the policies and practices of your organization. And by compassion, I mean going beyond empathy. So it's not just noticing and feeling what's happening in someone else, but also finding ways to act upon, to take action about someone else's suffering. And we spend so much time in our workplace that this is a really, really good place to start if we're going to practice and promote wellness and resilience in ourselves so that we can better serve those with whom we work. In creating a culture of health, encouraging self-care, and I know that's become a buzzword now, and I guess I have to use it because it's so important, that those of us doing the work really have to take care of ourselves. We have to address our physical well-being. We have to be as interested in our nutrition as we are in the nutrition of the infants for whom we work and their mothers. We have to find ways to exercise, and we have to find ways to modulate our stress. What are those practices that we have? How do we pamper ourselves? What exercises do we have around being quiet, being present, being reflective, and being introspective? All of those are very, very important in doing the work, working towards a culture of health, not just for those whom we serve, but also for ourselves. And finally, why should we? And I just wanted to borrow this very, very simple quote from Kathleen Kendall Tackett, who said, "Breastfeeding can make the world a happier place, one mother and baby at a time." And I think the time is now that we need to make our world happier and more peaceful. So I would like to end here. I know that I would be very interested in hearing from you if there are any questions, and I am happy to focus more on some of the issues around trauma and stress that I raised, but not knowing exactly who is in the space. I didn't want to make assumptions about what you know or don't know about trauma. So the questions would be very helpful for me to be more specific.
Thank you, Dr. Shervington, for such a powerful presentation. Yes, we do have questions. And Shakita Lewis Johnson says that, in most underserved communities where the greatest burden of a lot of the stresses, there are lack of resources and assistance for mental health. From your experience, are there any efforts at play that will increase access to these services? How do we, really work together as breastfeeding advocates to help get our mothers the right services in under-resourced communities?
Yeah, that is, of course, always the challenge. And I wish I could wave the magic wand and there would be culturally appropriate services that exist. I think one thing that's important is really knowing what the mental health system is like in your community, and really being able to, we know that there is more and more information about, if nothing else, postpartum depression and how it can negatively impact a woman and her child. I know over my career, 30 years in psychiatry, I've seen some extremely negative outcomes of postpartum depression. So I think that's usually a good place to start, in that there's more attention and perhaps maybe, and I'm going out on a limb here, someone can correct me if I'm wrong, there might be a little bit less stigma And especially now as we're beginning, the psychoneuroimmunology is beginning to show that there are really elevated levels of inflammatory proteins in a woman's body in the last trimester and after giving birth. I find in this culture that when things are taken into the biologic realm and it's not as environmental, that there tends to be a little less stigma. But I think that, it comes really from knowing what your mental health system is like and pushing the envelopes to say that this is important. It's a kind of advocacy that I've been involved in here in New Orleans, slightly different, but for young people in a post-disaster environment. Unless someone is willing to be a champion for these issues, public mental health systems tend to focus primarily on the persistently and seriously mentally ill and see everything else as someone else's challenge. And that should not be so. The public mental health system should respond to the prevalence of mental conditions in the communities that they serve. Certainly the more serious and persistent mental illnesses, the psychotic illnesses, we need to have a focus on that, but there's nothing that says that this is what a mental health system should be limited to. And providing, in particular, what would tend to be more psychotherapeutic supports, because we probably are not going to want our mothers taking medicines. That if they don't have to, we don't want to put them on our psychiatric drugs unless, there are issues, significant issues at stake here. That means that we need to be able to have the therapists in our communities, social workers, psychologists, who can engage in talk in psychotherapy. We do know that there are effective psychotherapies, primarily in the cognitive behavioral realm, that really help to mitigate and to resolve depression and trauma-based illnesses.
Very true. So really understanding the mental health scene in our own communities and counties and advocating for the kind of psychotherapy and counseling that would help women without just the chronic acute high cases. Another question on, strategies. How do we, when we work with our populations, how do we destigmatize mental health issues among many of them do not want to seek help. So some strategies in destigmatizing it even within our populations?
Yeah, one effective methodology, but it takes a little more time, is to sit with the community and have people here in New Orleans, we conduct what we call wisdom circles. And we bring forth different reasons. We bring community members together to get into in a safe space, and we use the word, we try to make it seem sacred, whatever that means for people. I'm not invoking religion in any way, but to say this is about interrogating our truths and the ways in which we understand the conditions that we find ourselves in. And I find that, for example, what happens with trauma, trauma is an external event that happens in one's life that overwhelms one's capacity to cope. And what I have found helpful is to say to people, when these things happen, it is normal for you to be psychologically reactive. Indeed, if you did not respond with psychological hyperactivity, which means basically that you're putting your survival system in a little bit higher gear so that you can address what the threat is. If you did not have that response, then something might be slightly abnormal, because we're all wired to try to survive as best we can. So I find that when that's the attitude that we take, and to say these continual stressors of poverty, of undereducation, of not having a living wage, they impact your body, your hypothalamic pituitary axis. You have a lot of cortisol running around in your body, and you do need, at some point, if it becomes overwhelming, it's important to seek help. I find that when presented in that way, that people are much more responsive and are much more likely to feel that it's okay to seek help.
Mm-hmm. Mm-hmm. Thank you. And do you recommend ACEs screening as a routine practice at some point during the pregnant postpartum period, Dr. Shervington?
Yes. If nothing else, it starts the conversation and it alerts I'm just assuming ACEs screening with mother. It alerts her to, there are some issues that I have faced that I need, and I often, we know that oftentimes for many women, giving birth is a very altruistic space. And if she can understand that if you are running around with all of this trauma in your body, it's going to be really, really difficult for you, as best as you want to be the best mother you can be with your child. And to reflect back to her that, again, these things that happened to you, these ACEs, were not your fault. They happened to you at a vulnerable period where you could not defend yourself or mitigate well against those stressors. Then I think if we screened for those ACEs, we could open up that conversation for her, and she could begin to ponder the possibility that maybe I too need help, if not for me, which hopefully I hope that's the reason we want her to do it, but if not for me, at least to be the best mother I can be for my child. Then I think it would be really helpful to routinely screen for ACEs.
Thank you. We have a cluster of questions which are asking about, in supporting mothers, what are some strategies for you that have worked? So you mentioned the wisdom circles. Is it something like the Red Tent wisdom circles that you've done in New Orleans?
Yes.
Could you speak a little?
Yeah, because as everyone is suggesting, I shouldn't say everyone is suggesting, but if you're working in low-income communities, we know that there's not access to the appropriate quantity of mental health services, and oftentimes the quality is not what it should be. Again, in communities that have such high levels of stress, we should have the most expert mental health professionals working with us, but we don't. We oftentimes are the least qualified. So that being said, my organization, we have really thought about what can we do at the community level to create wellness. At the same time that we're working on policy and trying to impact the mental health system, what can we do in the meantime, in the present moment? Because some people can't wait till a policy gets enacted 10 years from now. So we started conducting what we call red tents, and we kind of borrowed that from the well-known book, The Red Tent. And what it is really creating a very beautiful space. And we do that with tents, and they're red, and they're decorated with beautiful fabrics and flowers. And I focus on this because oftentimes this is what the women feel was so healing for them, to just be surrounded with beauty. And we bring women together in groups and we talk about these issues, and it varies. And it varies depending on the age and the issue for which we did the red tent. But the most important thing is creating this very beautiful, underscore pretty, safe, and as best you can make it, confidential space in which women can sit and focus on themselves, as they did in that book that was written about what happened in biblical times. And we then will offer, as we get community volunteers, or they don't charge us as much as they would in their private professional practices. We have massages for women. We might have yoga. We have acupuncture. And this just begins that process of healing. And oftentimes it's the support, the community support and feeling valued that begins that initial step of healing for women. As I say, I don't think that that is all that needs to be done, but that's certainly creating community wellness events. And I'm not talking about health fairs. I'm talking about really a focus on wellness. That we have found that this has really created an environment in which women feel better and they feel more energized to address the challenges that they're facing. And if indeed that means that they need to seek more mental health services, many do. I oftentimes, at the end of them, women will call me and ask me, is there a referral? Do I know someone? Can I see them? But it at least begins that process of, again, destigmatization and allowing a woman the quietude to begin to recognize the issues that are ongoing for her, the challenges.
Wonderful. Thank you. Please keep your questions coming. We still have some time. And while IWES has this wonderful white paper on resiliency, Dr. Shervington, and in your talk today, you focused on how we, as we work with one mother at a time, how we should be keeping the context and in mind as we build the culture of health in our communities as well. So could you tell us a little bit about some of the wellness evaluations that you have for your community action, again, in New Orleans, the We Can?
Yes, well, and this, even though New Orleans is a post-disaster environment, post a natural and political disaster, I don't think we are much different from many poor communities, low resource communities, whether they're in urban or even in rural settings. And what we found as we were working with young people who were totally ignored and have been ignored by the planning and mental health services here in the city, was a really level of post-traumatic stress disorder. And if there are people, as I said, I didn't want to make assumptions. If anyone wants for me to spend a little more time on PTSD and what it looks like, I'm certainly happy to. But we found very high levels of post-traumatic stress disorders and depression in our young people, 2 to 3 times the rate that exists nationally. And so we decided, and so of course there have been resources coming into the city to try to address some of the challenges that we're facing. But we find that folks are coming in with their own constructs of what is wellness for our community. And we decided that the best way to figure that out was to talk to the community itself. What do you see as your challenges, and how will you know if you're well? So we engaged on a 3-year process, started out with a group of young people because we were primarily looking at wellness in young people. And many of these young people we know are possibly going to be parents at an early age. And we worked with them over a year. We taught them about research and research methodology. And after a year, they went into the community with their colleagues, with other young people, and they conducted surveys and focus groups to find out from young people what it is that they think are the markers of well-being and wellness, and what are the things, what are the issues that they face that get in the way of being well. And after we did that, we convened a panel of experts, people who work in this area, and we gave them 90 constructs of well-being. And they also had the constructs that our community had determined were measures of their well-being. And so together we created a consensus process to define what wellness looks like. And I must say what we found is that social and emotional well-being was what young people and the stakeholders agreed on was the most important and best measure of their well-being. So their emotional health and their social connections in their families and in their neighborhoods.
Mm-hmm.
And I think, as we talk about, one of the things that I mentioned earlier was working with young people to build self-esteem and body pride. And I think that if we see breastfeeding as going before a woman and her partner bear a child, that if we do some of the early work, then it becomes much less of a barrier we have to overcome in the individual. Again, I mentioned my colleague who works here. She's really confident. She says, yes, of course I do this. I feed my child in public and I feel good about it, because she really feels good about herself. And she feels good about being a mother, and she feels supported in the workplace and in her family. But I think it also started with, as a young person, feeling good enough about herself so that she could succeed professionally and also as a mother.
Thank you. Yeah, and we did have questions. I'm glad you're showing this slide, because we did have questions saying they wanted to go and revisit what ACEs meant, and it's the adverse childhood experiences, and these are some of the ways that, so when there was a question raised about the ACE screening, people just wanted to know the full form of that.
Yeah, and I can just say a little bit, actually had the pleasure of hearing a presentation that Dr. Felitta did a couple of years ago about ACEs. He and the Andia at the CDC are the ones, and I refer people, if you're familiar with it, it's really now popular, and you can Google it and the material will come up. But what Dr. Felitta did, and he is an internal medicine doctor, he wasn't even a psychiatrist, but he was working with weight loss with women at Kaiser Permanente. And I'm sorry, I shouldn't just say women, it was just in his patient population. And there was a particular woman who was very overweight, like in the 300 pounds, who came to him. She worked at the hospital at Kaiser, and she said, I really, really need some help with my weight loss. And so he worked with her over a year, and she lost a lot of weight. She lost 160 pounds. She was doing well. And then she dropped out of treatment, and when he saw her again, 4 months later, she had gained back the weight and gained even more weight. And so he began a process of interrogation with her. And what he found out was that after she lost the weight, she became much more sexually attractive and began dating. But when she began dating and there were sexual advances, she got overwhelmed. And eventually that led to her recognizing an early history of sexual abuse. And so based on that experience, he decided he was going to really, especially with folks who were coming into his clinics, and in particular those in the weight loss clinic, that he was going to screen them for early experiences of abuse before age 18. And so that began, he started working with the Centers of Disease Control, and they came up with the domains, the full domains in which they would screen. And they did this with over 1,700 participants. And so I think that is really valid and generalizable. And actually someone asked him at the presentation that primarily the population was white and middle class. And he asked, would you consider doing this in a poorer and more colored population? And he felt that he wasn't being callous. He said, if it's this bad in this population, you can imagine that it's even worse for people with all these inequities. And so since that, people have, I know in Philadelphia, they have really, they've adapted the ACE. They said, there are some particular issues for people of color. So they've added a few more questions around incarceration and experiences with racism and the criminal justice system. The folks have even taken it a bit further. The Prevention Institute in Oakland, they actually look at adverse community events, experiences, because not only is the individual living in a family, they're also a community. So they address those factors at the community level, issues like blight, issues around lack of economic opportunity, and look at how at the community levels these things are interacting with individuals to create toxic stress and lower the capacity for resilience.
Mm-hmm. Thank you. Yes, and we have a lot of comments coming in about what our own providers on the line have been doing. So many of our lactation consultant here, Rani Patel, says that I've found asking a broad question to the moms during their postpartum appointment. How do you feel after the baby has come? Just asking and constantly being intentional about asking them how they feel, how are they coping, is really important to set the grounds for some deeper level conversations about mental health issues they might be having. And then also, this is a quote from interview you did, Dr. Shervington, with Doctors for Reproductive Justice. And I just want to quote this because this is so important for all of us in our field. And this was about physicians being reluctant to take on the activist role. And you said, if we are serious about the gifts we have as physicians, this could be applied to healthcare providers here too. If we are serious about the gifts we have as physicians, if we really want to see ourselves as healers, then we need to take a biosocial approach to individuals and systems in which they live. We should be involved in issues that are socially just and promote healing. Physicians have a duty to support human rights, including the rights of reproductive autonomy. So, such powerful words. And how would you, ascribe that to the field of lactation support providers as well? The healthcare providers, the vast network that do this work.
Well, I must say that perhaps you all are more compassionate. I think sometimes the practice of being a doctor can separate us from that deep compassion that compelled so many of us to become physicians in the first place. At some point, I don't know, and it's multiple reasons, and I love my people, so I'm not outing us, but I think the stress of being a doctor at multiple levels sometimes, we forget sometimes how just important it is to recognize that health is micro and macro, and that things in our environment are as significant to our health as the drugs we might prescribe or not. And I'm saying that I think that oftentimes other folks in the health field get that a little bit more, or are able to be with that a little bit longer. And so I think it is just really not separating our humanity from those that we serve. Certainly, I have perhaps a professional hierarchy. I have knowledge, maybe a little more knowledge than the person I'm serving about anatomy and physiology and health and disease. But that does not make me or make them any less human than I. And so how would I want to be treated? And I've had my experiences as a patient in my profession, and it's like, wow, this just, every time that has happened, it's just made me say, I want to be a better doctor. I don't want to not care fully, not sit with and really engage with my patients, my clients, whichever word you use, as a full human being, and address as best I can the issues that impact them. And so I think for lactation specialists, that to the extent that these inequities create the toxicity that impact the women that you're serving and their families and their babies, to the extent that you can be engaged in advocacy work, or even sometimes just education, because the woman and her family might become their own advocates. They might not need to have legislation. Sometimes just being very informed and being able to demand certain rights is all that's necessary. And so I would encourage you to continue to see that as significant a role as it is in teaching a woman how to position herself and the baby.
Wonderful. Thank you again, Dr. Shervington, for such a powerful and wonderful presentation. We've recorded this, and the archives will be available, and I know our audience will be listening to this again for all this great info. We still have a little few minutes if there are any questions coming. Okay.
I also want to apologize for whatever technical difficulties that might have interfered once again. I apologize for my city.
No, yeah, we could hear you. There was just, it did not detract at all from your presentation, Dr. Shervington. So, well, thank you, thank you, Dr. Shervington, and thank you, everyone, for all you do to improve the lives of women, children, and families. So until next time, goodbye.
Goodbye, and thank you.
Thank you.
Thank you.